All right, let's talk about mastering microcollection. We're going to break down the absolute must-know rules for capillary blood draws. This isn't just about acing your phlebotomy exam, though you will. It's about building that rock-solid confidence you need for your day-to-day work. So can one small mistake really invalidate a diagnosis? The answer is absolutely yes. In microcollection, precision isn't just important, it's everything. One tiny slip-up can mess up a sample, and that means a redraw, a delayed diagnosis, or worse. So here's what we're going to do. We're going to build up your skills by covering 4 key areas. First, we'll talk about why this all matters so much. Then we'll walk through the step-by-step workflow. After that, we'll cover what happens after the draw, how to handle that precious sample, and finally, we'll talk about when a capillary draw is actually the wrong call. And stick around, because at the end, we've got a rapid-fire review of the stuff you're pretty much guaranteed to see on your exam. Ready? Let's get into it. So we're starting here for a reason. Once you really get the why, the how just clicks into place. See, being competent isn't just about checking boxes on a procedure list. It's about taking those standards and turning them into results you can stand by, results that are reliable and, frankly, legally and medically defensible. It really all comes down to professionalism. I love this definition, especially that phrase, unified choreography. Just think about that for a second. It's not some clumsy, awkward shuffle, right? It's the smooth, practice dance where every single move, from picking the right device to getting rid of it safely, is done on purpose and done right. This isn't about just getting it right once in a while. It's about building a workflow that becomes total muscle memory, something that protects your patient, protects you, and protects that sample every single time. That is the standard your exam is based on.
Okay, so now that we have that foundation of competency locked in, let's get to the main event, the collection workflow. We're going to break down the whole shebang from getting your gear ready all the way to that final, crucial step of safe disposal.
So here it is, the whole process in a nutshell. These 6 steps, this is your blueprint for a perfect draw. You've got selecting the right gear, prepping the site, a good clean puncture, collecting in the right order, handling the sample correctly, and then finishing up safely. Now let's zoom in on the parts that are really, really critical. Your equipment is a huge deal, and trust me, knowing the details is a big ticket item on your exam. Let's start with the lancet. That depth limit for an infant's heel, 2.0 millimeters or less, that's a non-negotiable rule. It's all about preventing bone injury. Then you've got your microcollection tubes. You have to hit those fill lines or your blood-to-additive ratio will be off. And for those capillary blood gas kits, you'll hear them called CBGs, the collection has to be totally bubble-free and sealed up tight, like within seconds. Every tool has its own set of rules, and you've got to know them. Okay, let's talk about something incredibly important, the capillary order of draw. And listen up, because it is different from a venous draw, and you have to get it right. So why this order? Well, we grab blood gases first because they're super sensitive to air. The second you make that puncture, the sample starts changing. Next up is your EDTA tube for hematology. You got to get that blood mixed with the EDTA anticoagulant right away before tiny little microclots start forming and messing up your cell counts. After that, you've got your other additives, and last are the serum tubes, the ones that are supposed to clot. This sequence is a core concept. You absolutely have to have this down. So you've got the sample. You're done, right? Not even close. Your responsibility doesn't end with the puncture. That journey from the patient's bedside to the lab analyzer, well, it's a minefield of potential errors. This part, the chain of identity and stability, is where a perfect collection can totally fall apart if you're not careful. This right here, this might be the single most important rule in all of phlebotomy. Seriously, it's unbreakable. There are 0 exceptions. And here's why. It's your #1 defense against what we call a wrong blood in tube error. Labeling that sample immediately, right there with the patient, before you even think about leaving. That's the only way to be 100% sure that sample belongs to that person. No distractions, no "I'll do it in a minute," period. And this is what happens when that rule gets broken. An unlabeled tube isn't just a hassle, it is a major patient safety risk. You can't guess, you can't assume. The policy is always to reject it and recollect. Why? Because it protects that patient from getting a diagnosis or worse, a treatment based on someone else's blood. And here's a huge tip for your exam. The right answer is always the safest answer. And that means you reject any specimen you're not sure about. This right here shows you exactly how what you do at the bedside connects directly to the lab's computer system. Everything you write on that label has to match what's in the Laboratory Information System, or LIS, perfectly. And notice how for every single one of these, you have to note the source as capillary. That is so important, and we're about to see exactly why. This also shows how those little handling details, like inverting a tube a certain number of times or protecting it from light, become a permanent part of the patient's record. You know, a big part of being a pro isn't just knowing how to do your job, it's knowing when not to. Trying to force a capillary collection for a test that's not right for it, that's a huge mistake, one that can seriously delay a patient's care. So let's talk about the limits. So remember how I said labeling the source as capillary was a huge deal? Well, here's why. Capillary blood is just different from venous blood. It's actually a mix of arterial blood, venous blood, and tissue fluid. And because of that, some values are different. For example, glucose is usually higher in a good capillary sample, but other things like total protein and calcium are lower. Now, if the lab doesn't know where that sample came from, they might use the wrong normal values to interpret the results, and that could lead to a totally wrong clinical decision. Okay, this slide is your stop, do not pass go list. You really need to memorize this. For tests like coagulation studies, your PTs and APTs, you need a very specific amount of blood that you just can't get from a finger stick. Blood cultures, they need way more volume and have to be perfectly sterile. Same goes for tests like the ESR. For any of these, capillary collection is a non-starter. The lab will just reject the sample, guaranteed. All right, let's wrap this all up. It's time for the rapid-fire review. We're about to hit the most critical, most common concepts that you'll see on the exam. This is the stuff you want fresh in your mind when you walk in to take that test. Number 1, infant safety. Heel puncture depth. The magic number is 2.0 millimeters, maximum. Don't forget it. Go any deeper, and you risk hitting the heel bone, the calcaneus, which can cause a really nasty bone infection. This is a huge safety point on the test. Next up, the capillary order of draw. It always starts with blood gases. You have to get them before air can mess with the sample. Then comes EDTA to stop the clots, then other additives, and serum is last. That order is non-negotiable. Sharps safety. This comes straight from OSHA, so you know it's serious. That used lancet goes immediately into a Sharps container right where you used it. The second you're done with it, it's gone. Don't recap it, don't set it on the tray, it goes straight into the bin. It's all about preventing needle sticks. Capillary blood gases. These guys are high maintenance. You need to sample with 0 bubbles. You have to seal it airtight on both ends. Then you mix it with a little magnetic sleeve to get the heparin spread around. And then you have to run, not walk, to the analyzer. Any delay, any air, and the sample is useless. Let's talk about those EDTA tubes for your CBCs. Mixing is everything, and that means 8 to 10 gentle, full inversions. We're talking turning it completely upside down and back again, not shaking it like a cocktail. You need to coat all those cells with the anticoagulant to stop the microclots that will absolutely wreck your results. Okay, neonatal bilirubin. The key here is that bilirubin hates light. It's light sensitive. If you let that sample sit in the light, the bilirubin starts to break down, which will give you a falsely low result. And that's dangerous. It could mean a doctor misses critically high levels in a newborn. So use an amber-colored tube or wrap it up right away. And last one. Let's circle back to that key difference we talked about. When you warm up the site, you arterialize the blood flow. That's a fancy way of saying it has more oxygen and a higher concentration of things like glucose, so it's more like arterial blood than venous blood. This is a classic test question, so lock it in. Glucose is typically higher in a good capillary sample than in a venous sample. So there you have it, the blueprint for doing this right, safely, professionally, and competently. Look, this is about way more than just passing an exam. It's about realizing that every single one of those tiny drops of blood holds someone's story, critical information, and it's your job to protect it all the way from the patient to the lab. You're not just a collector, you are the first most important link in the diagnostic chain. Now go out there and make every single drop count.